All right, today we're going to break down a condition that I'm sure you've seen in your practice, even if it sometimes flies under the radar. We're talking about oral allergy syndrome. We're going to get into that crucial and frankly fascinating link between something as common as hay fever and some really surprising food reactions.
And right up front, it's really important to note that all the excellent material we're covering today is credited to the incredible work of Dr. Mohammed El-Nagi Mohammed.
So let's just jump right in with a classic case. Picture this. A patient comes in, you know they have seasonal allergies, especially to birch pollen. They tell you, "Doc, every time I eat a raw carrot, my tongue gets super itchy. It lasts maybe 20 minutes, then it's gone." So, what's jumping to the top of your differential diagnosis? Just keep that exact scenario in your head as we move through this.
To get to that answer, here's our game plan. First, we'll nail down what oral allergy syndrome actually is. Then, we'll contrast it with a true food allergy, a really key distinction. We'll look at the clinical picture, walk through the diagnostic pathway, and then wrap up with some really practical advice on patient management.
Okay, so what is going on under the hood here? Let's get into the science of OAS and this really interesting pollen-food connection.
So, the official definition is that OAS is an IgE-mediated hypersensitivity reaction. But for us, clinically, there are three things to really lock in on. 1, the reaction is triggered specifically by raw plant foods. 2, it's all about cross-reactivity. And 3, the patient's body was originally sensitized to pollen, not the food itself. That's the key.
So, how does this actually play out? Well, it's a three-step process. It starts with sensitization. The patient develops IgE antibodies against a specific pollen protein, let's say the BETV1 protein in birch pollen. Step 2 is cross-reactivity. They eat a raw carrot, which happens to have a protein that looks structurally very similar. Finally, step 3 is the reaction. Those IgE antibodies, which were made for the pollen, mistakenly latch onto the carrot protein and trigger a very localized reaction right there in the mouth and throat. It's a case of mistaken identity.
And that whole localized reaction idea brings us to what is probably the most critical distinction we need to make for patient safety: how to tell the difference between OAS and a true, potentially life-threatening food allergy.
At a high level, the difference is actually pretty straightforward. With OAS, the whole mechanism is about cross-sensitization to pollen, and the symptoms stay put in the mouth and throat. With a true food allergy, the body is directly sensitized to the food itself, and that's what can lead to systemic, body-wide symptoms.
Let's dig a little deeper, because it all comes down to the allergen itself, specifically its stability. This is crucial. In OAS, the proteins causing the trouble are really fragile. They're unstable. Heat from cooking or even just stomach acid breaks them down easily. That's why cooked foods are totally fine and why symptoms don't spread. But in a true food allergy, those proteins are tough. They're stable. They survive cooking, they survive digestion, and that allows them to get into the bloodstream and trigger systemic reactions, which of course can include anaphylaxis.
Okay, so we know what it is. Now, who gets this and what does it actually look like when they walk into your clinic? Let's get into the clinical picture.
And the numbers here are pretty eye-opening. While OAS affects maybe 2% of the general population in the UK, that number just skyrockets in patients who already have pollen allergies. We're talking about half of all patients with any pollen allergy reporting OAS symptoms. And get this, it jumps to a staggering 75% for patients with a birch pollen allergy. So yeah, this is way more common than a lot of people think.
Honestly, the history is everything when you're diagnosing this. You listening for that classic story, a patient with seasonal allergies who gets this rapid onset of oral symptoms, the itching, the tingling, pretty much immediately after eating a specific raw food. And just as important, these symptoms are fleeting. They're gone, completely resolved within an hour or so. And what's really cool is that these associations aren't random at all. They're very specific. Our patient from the beginning, the one with the birch pollen allergy reacting to a carrot, that's a textbook pattern. Birch is also linked to things like apples, celery, and hazelnuts. Ragweed pollen is famously linked to bananas and melons, while grass pollens often cross-react with tomatoes and potatoes. Knowing these common clusters is a huge diagnostic clue.
So, your clinical suspicion is high, the story fits perfectly. How do you go about actually confirming the diagnosis? Let's walk through that pathway. Okay, I'm going to say this loud and clear because it's the most important point here. This is a clinical diagnosis. Full stop. If the patient's story has all those elements we just talked about,
the pollen allergy history, the rapid, localized symptoms to a specific raw food, you are pretty much there. The history is your #1 diagnostic tool.
So where do investigations fit in? Well, they're supportive. They're not the main event. You can absolutely use standard IgE, RAST, or skin prick tests to confirm that underlying pollen allergy, which just strengthens your case. And if you really need to confirm the sensitivity to the food itself, a skin prick test using the actual raw food can be helpful. A positive test will give you a little itchy lump, confirming the sensitivity.
Now here is a massive clinical pearl and a common pitfall to avoid. Those standard food-specific IgE blood tests, they are unreliable for OAS. Why? Because the commercial processing they use to create those test kits often destroys the very same unstable proteins you're trying to detect. This leads to false negatives all the time, and it's a key reason why you have to rely on the patient's history first and foremost.
Okay, we've nailed the diagnosis. Now for the most important part of our job, right? What do we tell the patient? Let's cover management and counseling. The management plan is refreshingly straightforward, and it's tiered. Step 1 is simply avoiding the trigger foods, but only in their raw form. Step 2, for those times when accidental exposure happens, is to just take an oral antihistamine to calm down the local symptoms. And Step 3, the emergency plan. Now, while anaphylaxis is extremely rare with OAS, we still need to counsel patients on the warning signs, wheezing, hives, a drop in blood pressure, and tell them to call for help immediately if they ever experience anything systemic.
And this right here, this is the single most important, most empowering piece of advice you can give your patient. You get to tell them they don't have to give up these foods entirely. Cooking changes everything. It denatures those unstable proteins and makes them harmless. So our patient who can't eat a raw carrot stick, a nice bowl of hot carrot soup should be perfectly fine. This is a total game changer for their quality of life.
So let's just end with a thought for you to take back to your own practice. We all know that factors like climate change are altering our pollen seasons. They're getting longer. They're getting more intense. So how might this affect what you see day to day? Are we going to start seeing a higher prevalence of OAS? Maybe even new pollen food associations we haven't seen before? It's a really dynamic area and definitely one we'll all need to keep an eye on.